Alright, so welcome to week 8. So this week we're going to talk about adjusting. So we're going to talk about a little bit about the neural mechanisms and what happens in the tissue level when you deliver adjustments, and how can we bias different kinds of adjustments, having the understanding of muscle spindles and GTOs, the Golgi tendon organs. Then we're going to talk about reflexes. So we're going to talk about pathological, the primitive reflexes, and myotatic stretch reflexes. So it's going to be a week packed with information, but it's going to be a really exciting one, so I hope you enjoy it. So let's talk about some of the goals for tonight. So like I mentioned, we're going to really dive deep into muscle spindles and the Golgi tendon organs. I'm going to talk about in general what is the importance of adjustments. Then we're going to talk about how do we bias different pathways by using fast stretch versus slow stretch adjustments. And then at the end, we're going to wrap with myotatic stretch reflexes and pathological reflexes. Alright, so let's jump right into the muscle spindles. So the muscle spindles are super crucial for getting that afferent information from your body and your muscles to let your body and your brain know where you are in space, okay, where your muscle is at the current moment. So it's going to detect the stretch and the speed of the stretch of the muscle at any given time. And the muscle spindles are located in the muscle belly. Okay, so in the outside here you have the extrafusal fibers. I hope you can see my laser, it's pretty bright here. But you have the extrafusal fibers here in the outside that are innervated by the alpha motor neurons. So those alpha motor neurons come in and they activate, they create action potentials to make a contraction happen, and then inside of those extrafusal fibers you have the intrafusal fibers, which are our muscle spindles. So we have nuclear chain fibers here and then the nuclear bag fibers, okay? And wrapped around those intrafusal fibers we have the annulospiral sensory neurons and then the flower spray sensory neurons. Okay, and the biggest difference between those two is that the annulospiral sensory neurons are called our group 1A afferents, and those are actually one of the fastest messengers we have in our nervous system. Then we have the flower spray sensory neurons that are called group 2 afferents, and the biggest difference between those two is that the annulospiral sensory neurons, those group 1A afferents, are receiving dynamic changes or detecting dynamic changes in the muscle length. Okay, so if I go ahead and contract my bicep like this, the amount of or the speed of the stretch was detected by those annulospiral sensory neurons, and also the amount of stretch in general you got from that contraction, or if you lengthen the muscle, either way. And then the flower spray sensory neurons, those group 2 afferents, are taking information more of the about the absolute length of that muscle. So even when you're static, you're not moving, you are getting a lot of afferent information into your brain, into your cerebellum, letting you know where those body parts are in space. So you can kind of start understanding how important this system is. But the most exciting part of all of this is that these intrafusal fibers, these muscle spindles, are modulated by the central nervous system, by our brain. And if you remember from last week, it's the PMRF that we're going to start talking about it yet again. So how it does that is through the gamma motor neurons. So here we have the gamma efferent fibers to the intrafusal fibers. Okay, so what the gamma motor neurons do is, I'm going to go to the next slide so you can read about it a little bit more. But so the gamma motor neurons are in the polar ends of the intrafusal fibers, and they're making sure, the gamma motor neurons making sure that those muscle spindles move with the actual movement of the extrafusal fiber when the muscle belly gets shorter or it lengthens. So let's say I do a bicep curl like this. What happens is I shorten my muscle, those actin and myosin filaments come together to contract that muscle. Well, when that happens, those intrafusal fibers went off air that's kind of a way we say it, they went off air, and you're not getting enough sensitivity, or you're not getting activity from those intrafusal fibers because it's not tight and erect. It cannot take the information in of that change from stretch to another, or of movement to another. So what the gamma motor neurons do is that they will actually fire into the polar ends of the interfacial fibers to make it tight, and so it moves with the with your movement of those extrafusal fibers. So you are getting that information in at any level of degree of stretch of that muscle. Okay, and they are innervated by the brain. So the cell body is located in the ventral horn cell, and they're modulated by the PMRF. And once again, the PMRF is going to innervate, or it's going to activate this side of the body, and it's going to regulate the amount of gamma motor neuron activity. So a really fascinating system. So here's a really important concept. The greater the gamma motor tone, the more sensitive the muscle spindle is, equaling the more feedback to the system. So more gamma motor neuron activity, more sensitivity of those muscle spindles, more afferent information coming into your brain and letting you know where those muscles are in space and how fast did you stretch those muscles. Okay, it's really, really important. So in a good system, we want to have high sensitivity so we can have high reaction time. Okay, if you have really low sensitivity, you might do a movement and your brain didn't catch up with that movement, and you increase the risk of injury because you didn't even know where that body part was in space. You didn't know how fast that stretch or that movement happened. So really important to understand this concept. And it's one of the only receptors in the body that the brain can modulate, like I mentioned you before. So we can actually bias this gamma motor neuron activity by doing certain therapies and looking at our neuro exam and seeing how our PMRF functions. And now you already know if somebody has a PMRF dysfunction, you can see those four primary things that we talked about last week. You get this soft pyramidal paresis distribution, and you can start hitting some reflexes. You can start testing for the muscle tone. You can do some muscle testing. You can look at their sympathetics, and you're going to have a better understanding of what maybe this is a certain mechanism that's contributing to their symptoms or whatever they are coming into your office with or into your clinic with. Okay? So then let's talk about the Golgi tendon organs. So the Golgi tendon organs are all about detecting tension on the tendon. So it is a protective mechanism. So the T is your magical letter here for remembering what it does. Detecting tension on the tendon. Okay? So when you increase the load on the tendon, you are going to increase the activity of 1B afferents. And these are the Golgi tendon organs. Okay? Once the 1B afferents get that information from those Golgi tendon organs, they're going to fire into the spinal cord, and they're going to inhibit the alpha motor neurons for activating and contracting the muscle. So let's say you're doing a bicep curl, and I try to do a 100-pound bicep curl. Somebody puts it on my hand. My immediate reflex is to let it go. There's no way I'm going to hold that weight and make a contraction without actually damaging or injuring my musculoskeletal system. So the 1B afferents come in and they inhibit those alpha motor neurons so that I'm not going to do damage to my system. Okay? And we can actually bias this 1B afferentation by doing certain types of adjustments, and we're going to talk about that in just a bit. But when we talked about high sensitivity, now we're going to talk about gain. So we want to have a system with high sensitivity and low gain. And when I talk about gain, I talk about the amount of distortion, the amount of errors that are possibly happening in your system. And if you have increased amount of 1B afferentation, you're going to increase the gain, meaning you're going to have more distortion in the system. Okay, so we have low gain, high sensitivity, high reaction time to whatever you're going to do. So your brain knows what's going on, and you can have a balance in that musculoskeletal system, so you're not going to be hypertonic versus hypotonic. Okay, so let's talk a little bit more the brain and the influence on the muscle spindles. So the brain's general effect on the muscle spindle sensitivity and gain is through the modulation of the ipsilateral PMRF. Increased output of the PMRF results in increased muscle spindle sensitivity and decreased gain. Okay, so that's the whole idea. I hope I have stressed that enough and you can understand this concept. So let's bring in this neuroflow chart a little bit from last week and talk about how this plays a role in the muscle spindles and GTOs, and we can tie it together a little bit. So let's say I adjust somebody on the right side of their body. that information from the muscle spindles and the GTOs is going to travel into the right cerebellum, into the left cortex, and the left cortex, 90% of that cortex's output is going to go to the ipsilateral PMRF, and the PMRF is going to modulate those gamma motor neurons, which are going to modulate the sensitivity of those neurons. And remember, when you activate gamma motor neurons, you increase the sensitivity of those neurons, you get more afferent information coming into the brain. So now I increase the sensitivity of those muscle spindles through the gamma motor neuron activity on the left side of the body. Now I'm getting more afferent input to the left cerebellum and into the right cortex, right? So we started by stimulating more left brain, and then the left brain activity increased the left muscle spindle sensitivity to balance the right brain. So you see how this balance forms. It's absolutely super fascinating how this happens. And then with some people who get diascasis, for example, from a cerebellar lesion, so let's say you lesion in your right cerebellum, and now you're losing this proprioception and this muscle spindle activity from the right side of the body, you're going to get less input into the left cortex, the left frontal lobes, and you create this diascasis, which is just this dysfunction in one area of the brain due to dysfunction in another area of the brain, right? And then you start failing, the system starts failing, then we start looking at these different findings and seeing if there's a bilaterality into, or if it's only one side of the body that you see changes, or is it bilaterally, okay? So a really important concept to understand, and hope that makes sense to you, okay? So how do we bias the GTO activation? Let's say somebody has a hypertonic muscle. There's a lot of tone, there's a lot of alpha motor neuron activity and gamma motor neuron activity. There's too much of it. How do we bias GTO to create inhibition into that system so we can balance it out to have appropriate amount of sensitivity and appropriate amount of gain in the system? Well, the load on the tendon can be increased by less protein interdigitation, speed of the loading, length at which the muscle is loaded. Okay, so let's break this down. So if you have less protein interdigitation, that means that you have less muscle mass. And we know that elderly people often injure themselves way easier because they have less muscle mass. Okay, so if you have less muscle mass, you are biasing, or you're increasing the load on the tendons, and then you increase the 1B afferentation, meaning that those muscles and that system gets more hypotonic, and most of the injuries actually happen on the side of the hypotonicity. Okay, so that's one mechanism. Speed of the loading. Okay, so the faster or the more speed I have in me stretching my muscle or moving my joint, the more load you're going to have on the tendon and the more 1B afferentation. The length at which the muscle is loaded. Okay, so if you load a muscle in a lengthened state, you're going to have more Golgi tendon organ activity. Okay, so you can actually bias your adjustments. You can do the adjustments faster in a more rapid way, and you can adjust in different states or lengthening states of that joint to bias the 1G activity. And we're going to dig a little bit deeper into this in just a bit as well. So the main concept is that when the GTO is loaded, it reflexively inhibits that muscle, and it synergists and activates the antagonist. Okay, so when we talk about cross-cord reflexes, this is a really important concept as well. So let me just real quick check what I have on the next slide. Okay, so when we talk about this cross-cord reflexes, meaning that if I'm walking, for example, you're looking at gait. So I put my left leg in front of me and I flex my arm here. On the opposite side, I'm going to have the exact opposite. Okay, on the contralateral side, I'm going to have the opposite response. So here we're going to have flexion, and then on the opposite side, we're going to have extension. Okay, so that's a reflexive mechanism in the spinal cord, which is called the cross-cord reflex. So let's say that you have a PMRF lesion, or let's say you have decreased amount of cortical activity coming into your right PMRF. Okay, so you lost that activation. What happens is that if you remember from last week, one of the functions of the PMRF was to inhibit the flexors anterior to T6, above and anterior to T6, and below and posterior to T6. Okay, so you increase the activity of these flexors on this right side of the body, and now I'm getting more muscle spindle activity. I'm getting more afferentation into this flexor, into these flexors, And then by default, I'm getting more extensor tone because of this cross-cord mechanism. Increase activity here, increase activity in the extensors on the opposite side. So therefore, you're going to see hypotonicity on the extensor side here on the upper extremity, and then you're going to see hypotonicity in the flexor side here on the contralateral side. And then when we start talking about lateral epicondylology or lateral epicondylitis, or medial epicondylitis, or rotator cuff syndrome, piriformis syndrome, and all these different musculoskeletal issues, you want to start looking at the brain mechanism behind that. So like I mentioned, these degenerative symptoms or disorders usually happen on the side of hypotonicity. So let's say I have this PMRF issue on the right side. I have increased sensitivity here, and then hypotonicity, I have hypertonic muscles on the flexors and hypotonic extensors on the back of my hand. So we know that lateral epicondylitis is actually an issue with the extensor carpi radialis brevis. So it could be coming from a brain issue because you have less muscle spindle sensitivity and an increased gain on this side of the body, and that's increasing the load on the tendon, and therefore you're more prone to injury, and you start going through this degenerative process. Okay, and then you might start looking at what happens on this side of the body. Is there any issues there? Okay, so usually we say that the lateral epicondylitis can happen due to a ipsilateral hemisphericity, meaning decreased cortical activity on the right side of the cortex. And then you might see a medial epicondylitis due to a contralateral hemisphericity. Okay, because the medial epicondylitis is has to do more with flexor tone. So you might see a medial epicondylitis from decreased cortical activity on the right side and having these cross-cord reflexes and seeing this hypotonicity on this side of the body. So you start looking at all these orthopedic and these musculoskeletal issues as brain issues. Okay, I'm not saying that there's not other mechanisms behind there. Absolutely not. But you have to be able to look at and think differently and think neurologically what's happening and what is the motor output coming from that brain and modulating all these muscle spindles and GTOs and these gamma motor neurons, etc., and what is the consequence of that. So we always look at what is the type of input your brain is getting. Is it sufficient enough? Is it appropriate? So are we getting appropriate stimulation? And how is it integrated in your brain? And what is the central consequence? What is the motor output? And everything starts making a lot more sense to you, and you treating these musculoskeletal issues or pain disorders is going to get a lot easier too. Okay, so I hope you understand this concept. Let's keep going. So what is the power of an adjustment? Well, we talked about this one already. So the reflexive nature of the adjustment sends afferent signals to the brain and efferent signals back to the muscles to set the gain level, the resting tone of that muscle. So you adjust somebody, you bombard the system with all these electrical impulses, and your brain feeds off of that. Okay, like we mentioned before, more complex movement created more complex brains, and then we can have this top-down regulation or modulation. And when you adjust somebody, in addition to breaking these adhesions and these other mechanical things that happen, is you're going to have a lasting effect. So even after you adjusted a joint, research shows that that pathway keeps firing after that. So the adjustment results in long-term potentiation. How that happens is through these NMDA receptors that create a genetic response. So when you adjust a joint and you exceed its holding elements, you go into this paraphysiological space, you activate those NMDA receptors on the cell membrane, which is going to deplug the magnesium plug, and more calcium comes in, and as more calcium comes in, you are going to activate this immediate early cellular genes, and you're going to start making more protein. When you make more protein, you have more cytoskeleton structure, you start making more mitochondria, your neuron becomes healthier because you have more ATP now, and the whole system starts to get better. And remember that proteins have a negative charge, so that can balance the membrane threshold as well. So this is one of the multiple reasons, one of the dozens of reasons why adjustments are so important and how they're making people's central nervous systems better. Okay, all right. So Next, we're going to talk about the key to adjusting. So really important is for you to have the thought process of why do you want to adjust something, okay? Is it there for you? Because you want to reset the tone of those muscles, and you want to increase the amount of muscle spindle sensitivity, or you want to attack it from a cortical and PMRF side of aspect and think about how it affects that side of the body, or is it you want to break down those adhesions, or you want to increase more motion into those joints, and you start going through the thought process, and you have to have this thought process in order to make your patients better. You just can't go and adjust every single joint hoping for the best. It just doesn't work that way, because we know that every adjustment has a certain central consequence. So if that stimulation, if that adjustment wasn't appropriate for that patient, you might exceed their metabolic capacity. And I've seen that before. One of my mentors actually, he was put into a hospital 3 times by a chiropractic adjustments because it was way too much for his system, and his system was way too prone way too prone for that activity. So that's kind of not the greatest example I want to give you, but still it's there. You want to understand the system. And next, you want to understand what to adjust and where to adjust. Okay, so it matters if you're adjusting an extremity or the actual spine, or if you're adjusting a cervical versus a thoracic or a lumbar. Okay, so usually say closer to the brain, the more input you're going to get. So those suboccipital muscles have the greatest amount of muscle spindles per 1 gram of tissue. So you adjust a C1, C2, you're going to bombard the system with a lot more input than you would if you would adjust somebody at T7 or T8. Okay. So it really matters. And also you want to understand, do you want to adjust on the right side, do you want to adjust on the left side? Okay, and when to adjust. Do you want to adjust before your certain therapies or after certain therapies you want to do, or do you want to adjust them? How frequently you want to adjust them? Is it only going to be once a month kind of thing, or what is your plan with that? Because all these things really matter. The frequency of stimulation into your system is really going to determine a lot why and what kind of output you're going to create. Okay, so we talked about this. You want to know whether that adjustment will be beneficial or detrimental, and also one of the most important things is, can I co-activate different pathways while I adjust? So we talked about spatial summation week 1 and week 2, and so let's say you wanna co-activate your adjustment. So you adjust somebody on the left side of the cervicals. Well, now you know if you want to increase the left cervical activity, which way would you move your eyes to? Now think about it. So you would move your eyes up and to the left and down to the right. So you got it right, okay? And then, or if you want to balance the system, you don't want to really create so much activity into that one cerebellum, that one cortex, you can move their eyes up and to the right to create more right cerebellar activity, okay? Or do you want to adjust them lying or standing or sitting, okay? Those all matter. What about the vestibular system? What is the canal afferentation? What is the otolithic afferentation doing to that central nervous system? And what is their compensation looking like? Okay, so all these things start to matter. And then you can also think about doing certain parietal lobe mapping, temporal lobe, sound localization, and then you can add different smells, etc. Or you talk to the patient on one side over the other. You talk to the patient on the left side only to activate more of their contralateral cortex. Okay, so all these things start to matter, and it becomes a lot easier for you too when you start understanding how you can create different adjustments in different environments. Okay, it's gonna make all the difference. Just trust me on that. All right, so then a few rules for adjusting. Like I mentioned, the closer to the brain, the more impact on the central nervous system. Flexors have greater representation in the central nervous system, so we talked about that last week. So we used to be in this 4-legged animal, so we used to be in this flex posture, and therefore we had to inhibit these flexors to come here in this bipedalistic posture to activate our extensors. And therefore we still have greater representation for our flexors, so you adjusting a flexor over an extensor is going to create more activity and more stimulation. Increased range of motion, increased feedback to the brain. Input to the wrong part of the brain can compromise the patient's neurological well-being. We talked about that. and all movement-related receptors feed back into the cerebellum. Okay, really, really important concept, and I think you guys are grasping on that already. And then when you guys get into our advanced club, we're going to actually teach you guys how to perform these fast stretch versus slow stretch adjustments. Now I'm going to give you the concept. I'm going to explain to you how they work and why you want to use these. Okay, we already talked about them a little bit. But in our advanced club, we're going to teach you specifically at least 5 different adjustments for your flexors, for your extensors, on your upper extremity and lower extremity to bias different pathways, okay? But right now we can't really do it. We like to be active and actually touch our friends and do these adjustments so you get the most out of it. So, fast stretch. I want you to think GTOs. We already talked about the faster you move a joint through any range of motion, the more you're going to have bias towards the GTO activity. So what's going to happen, like I said, just a review, it's going to fire in the spinal cord via 1B fibers to inhibit gamma motor neurons and alpha motor neurons. It's going to decrease the tone of the muscle spindles, therefore decreasing the sensitivity. So you would do this to a person that has more of a bias over the hypertonic side of activation. So this is one of those things that we talked about. If you have this increased sensitivity here and the hypertonic muscles here due to a right cortical dysfunction and the right PMRF function, you could now perform faster adjustments on these flexors on this side of the body to bias this 1B afferentation, and then you want to do faster adjustments on the posterior side, on the opposite side of the body, because if you do these faster adjustments here, you bias 1B afferentation, you bias the inhibition, but also you bias the cross-cord reflexes, so you reset the tone on the other side of the body as well. Really, really fascinating system. Okay, so I want you to understand that concept. Then slow stretch. Slow stretch is more activation of the muscle spindles, and it's used for stimulation of the muscle groups. Relaxes the soft tissue before adjusting. Okay, so you could, for example, if you're adjusting somebody's cervicals, you could traction the SCM on the other side like this to bring more activity or bias into the GTOs to create a difference of a stimulation in your adjustment. Okay, there's so many different ways to do that, and we're going to show you all that in later of your learning process. Okay. So, is cavitation important? This is a question we get a lot, and in short, yes, it is. You know, I'm not saying that activators or other forms of treatments or adjustments are not as good. Absolutely not. There are time and place for all of those techniques as well. But depending on what you want to do, and if you want to reset the gain of that muscle and that system, usually you need the cavitation. Okay. So when you hear the cavitation, what really happens? Well, what happens is that you exceeded the holding elements of that joint, and you went into this paraphysiological state. And what that does, it'll activate those NMDA receptors, and it'll activate those immediate early gene responses to create more protein and to bring the threshold down and to reset the entire tone of that muscle. Okay, so you need to have that cavitation. When you go into the paraphysiological state, you release the gas from the synovial membrane, and that's how you get this gene response, and that's how you reset the muscle spindles and the GTOs in order to have this motor output or this mechanism or this consequence that you're looking for. Okay, so absolutely cavitation is important. All right. So then, let's talk about myotatic stretch reflexes. So a really important concept here is that the brain's output is to produce movement. I think I've said that at least 10 times already. And checking for a reflex is therefore checking for brain activity, because a reflex is a movement. Okay, it's something that your spinal cord and your brain is responsible for modulating and creating reflexogenically. Okay, so you want to look for resting muscle tone, and we talked about that already in the PMRF lecture. But let's talk about real briefly what happens when you tap a reflex. I think this is explained pretty well in school, so we're not going to talk about too much about this or too long, because I think you guys have a pretty good understanding of this already. But what happens is that you have a stimulus, and let's say you tap a tendon. What happens is you actually stretch those muscle spindles, and that afferent information, that 1A afferentation, comes into the spinal cord, where it's going to activate those alpha motor neurons that are going to activate the homonymous muscle. That's it. That's how simple it is, okay? And that's happening as long as there's no other mechanisms that are acting on those alpha motor neurons or that ventral horn cell, is that we have a normal response, okay? If you have a loss of inhibition, or you have too much excitation in that system, or you have a lower motor neuron injury, you might see different responses, okay? And we're going to talk about that. But then at the same time, when you hit the, you activate the muscle spindle, what's going to happen is it's coming to the spinal cord, and it's going to come in and activate the Renshaw cell to inhibit the antagonist muscle, okay? So you hit a tendon, or you stretch the muscle spindle, comes into the spinal cord, acts on the alpha motor neuron to activate the homonymous muscle, and then at the same time a Renshaw cell gets stimulated that inhibits a antagonist muscle, okay? That's how it works. Now let's talk about a little bit the reflex arc and what could be acting on those alpha motor neurons and that spinal cord that are giving us different responses when we are tapping or hitting those reflexes. So the cortex receives information and sends info to alpha motor neuron integrator. And the job of the frontal lobe, or the cortex, the upper motor neurons, is to inhibit those alpha motor neurons. Okay, we already know this. The upper motor neurons relay info to the lower motor neurons. Okay, so the upper motor neurons are in your brain and in your spinal cord, and anything that leaves your spinal cord are your lower motor neurons. Okay, so then we start talking about what happens if you have a upper motor neuron lesion or a lower motor neuron lesion. So here we have the diagram showing you that everything here in the green is a upper motor neuron. So traveling from the brain into the spinal cord and down at the spinal cord as well. And it's going to come in and inhibit those alpha motor neurons. Then everything leaving the spinal cord is going to be our lower motor neurons, our motor efferents, okay? So let's say that I have an upper motor neuron lesion. I cut this pathway from here. We no longer get inhibition into lower motor neuron, and now when I tap that tendon, I get that muscle spindle afferentation. Those afferents come in, those 1A afferents, those fastest messengers in the nervous system, come into the spinal cord and act on those alpha motor neurons to activate it, and now you get an excessive response because there is no mechanism that was inhibiting those alpha motor neurons. They were already so close to threshold that you get an excessive reflex, you get hyperreflexia, okay? A hyperreflexic response. What if we get a lower motor neuron injury? Well, a lower motor neuron injury means that we cut it right here or anywhere along this pathway. Now what happens is that when you get that sensory afferentation from those muscle spindles, they'll come in and activate those alpha motor neurons, but since there's nothing to actually activate the extrafusal fibers, the actual muscle, nothing's going to happen. So you're going to have areflexia or hyporeflexia, okay? Hopefully that's a concept you can understand. It's pretty simple. And now let's start talking about different presentations of these upper motor neuron lesions and lower motor neuron lesions. So I think this is really well explained to you in school in neurodiagnosis as well. So I'm going to just briefly talk about this so it's a good review for you guys and you can understand the system. So we're going to talk about type of paralysis, atrophy, and the amount of deep tendon reflex or myotatic stretch reflex you're going to see, and fasciculations or twitching. All right, so upper motor neuron lesion. You have something that has gone wrong. You might have an infarct, you have a tumor, or whatever is causing your upper motor neuron lesion. The type of paralysis you're going to see is spastic paresis. Okay, so you have hyperactivity, too much activity, you get the spastic response. Okay, but in a lower motor neuron lesion, you get flaccid, meaning you get hypotonic. There's not really nothing to act on those muscles. So upper motor neuron lesion, you lose the inhibition. Lower motor neuron lesion, there's nothing to really activate and create those action potentials traveling into the actual muscles themselves. Atrophy. Okay, so cell death. Are we going to get any atrophy in upper motor neuron lesion? Absolutely not, because we have too much activity. Okay, too much stimulation and too much muscle contraction. So we're not going to get atrophy. But in a lower motor neuron lesion, yes, you will, because you don't have anything to activate those muscles once again, and you lose the protein interdigitation in there, and then you have less actin-myosin activation, and then you're not really getting any muscle stimulation, and therefore you get atrophy. Deep tendon reflexes, upper motor neuron lesion, you get increased like we talked about, and then lower motor neuron lesion, there's really no response. Fasciculations don't happen in upper motor neuron lesions, but do happen in lower motor. So the reason why that happens is that you start kind of, from that extracellular fluid, you start giving acetylcholine into these areas randomly, and then you get this twitching in areas that don't really make any sense, perhaps, and then you get this excessive twitching, and it might go away and it might come back. Okay, so those are the main difference between the upper motor neuron lesions and the lower motor neuron lesions. I hope they make sense to you, and like I said, you are getting a pretty good introduction to this in school as well. But when we are doing our reflexes, and we're testing for the reflexes, you always want to test bilaterally. Okay, so you want to look at what is the response. And here we have a grade of 0 is absent reflex. That could be a lower motor neuron lesion. Trace plus 1 plus is trace or seen only with reinforcement. And the only seen with reinforcement means that we are doing a chin thoracic maneuver. So we're pulling apart like this, and you're clenching our teeth together like this to create more of this top-down regulation and to increase the activity in that spinal cord, so that now you have the stimulus, it's already close to the threshold, and now it can actually fire. I've seen that happen with a lot of people. Then 2 plus, normal response. 3 plus is brisk. 4 plus is non-sustained clonus, repetitive vibratory movements. So this is indicative of an upper motor neuron lesion, or sustained clonus, also upper motor neuron lesion indication there. So check bilaterally. What I want you to do is just grab your neurological reflex hammer, and then, or your reflex hammer, and then hit all these reflexes and check if there is appropriate response, if there is a trace amount, or if it's a little bit brisk, or you might see 4 plus or even 0, and see what you find. Usually we say on the side of hypotonicity you have decreased reflexes, like we talked about with the PMRF. You can also see a hypotonia due to a cerebellar lesion, or you might see a basal ganglionic lesion that's going to create more of a hyperreflexia, okay, the loss of inhibition. All right, so go ahead and practice that with your friends and see what you find. All right, so now let's talk about primitive reflexes. So the primitive reflexes originate from the brainstem, and they're executed without cortical involvement. So we're not supposed to see primitive reflexes in healthy adults who have a mature nervous system, but you will see this in infants from birth to 1-year-old. So after 6 to 12 years of age, you're supposed to inhibit these primitive reflexes by more of frontal lobe and cortical development that's going to come down and inhibit these brainstem reflexes. So they are there for survival. Okay, a child is equipped with a set of primitive reflexes designed to ensure immediate response to the environment. Okay, and they are directed from the brainstem, like I said. But on top of that survival mechanism, what these primitive reflexes do, they actually aid and enhance creating new connections in the brain and help the central nervous system mature. So they're going to create these, or going to help create these long-range connections from hemisphere to the other, and these short-range connections, and it's going to help establish muscle tone, range of motion. It's going to help the baby and the child move their head in different directions so they can actually move their visual field and have or move their eyes so they can actually detect the visual field around them and create vestibular input so they can actually create an appropriate functioning nervous system. Okay, so if the primitive reflexes remain active beyond 6 to 12 months of age, It's going to affect the proper neural development, and it's going to act as a sign of immature central nervous system. So we're going to show you how to test a few of these primitive reflexes, and you can see, and this could be a window into looking at how is their frontal lobe, how is their cortical mechanisms working, are they really inhibiting those brainstem reflexes, okay? So let's jump right into it and talk about the motor reflex. So the motor reflex is an involuntary reaction to possible threat, and it is the only primitive reflex to be connected with each one of the senses, meaning that any stimulus can actually trigger the motor reflex. And what the motor reflex is that it's sudden abduction and adduction of the baby's arms, kind of like shown in the picture there. And it's there for the baby to create a sympathetic response and alarm the mother that the baby might be in danger. Okay? So you get this rapid movement of your arms and your legs trying to cling on to something, and they start crying and they have a huge sympathetic outburst, and they go into this flight or fight mode. Okay? And it should be inhibited at 2 to 4 months of life. What I want you to do is go to YouTube and just type in motor reflex, primitive reflex, and see what it looks like in a baby. And then we're going to show you how to test this in an adult and what you might see if they actually still have a retained motor reflex. But let's talk about a child, for example, and they have a retained motor reflex. What you might see in that child is that they are really stimulus bound, or they're overloaded. So any stimulus, for example, auditory, visual, tactile, a change in vestibular input in the vector of the gravity, can actually trigger this motor reflex and cause a sympathetic outburst. Okay? You don't necessarily see the abduction and adduction of the arms as much. You might, but what really happens, let's say you get a loud noise such as a balloon that pops, that child gets scared of that auditory stimulus, and those frontal lobes didn't kick in soon enough, and that brainstem created that high sympathetic tone for that flight or fight mode, so you can actually survive, even though that balloon pop wasn't really realistic. It was nothing that's going to kill you. Okay, but you still get this sympathetic response due to the fact that your frontal lobes and your cortical areas are not developed to inhibit that reflex. And when that happens, you are in this continuous flight or fight mode. And when that happens, is you are going to start producing different hormones, and then different, you're going to put more stress on your adrenals, etc., etc. And what you might start seeing is that these sympathetic responses lead to some kids having poor immunity. For example, cortisol is one of the primary ways that you're going to fight against allergies and infections. And when you are in this flight or fight mode, what happens is that the cortisol starts diverging away from its primary function, and now you might not have sufficient stores of it, and this child might be the child who always gets every cough, always gets every virus or bacteria, and they're always sick, etc., because they are in this overly sympathetic tone, and they don't have appropriate system working together to create this neuroimmunology, okay, or these neuroimmunological responses. Then we have oculomotor and visual perceptual problems can come from this as well. Reactive hypoglycemia and mood swings, which also play a role in how the sympathetic nervous system works and this continuous fight or flight mode that it's on. Okay. Then let's talk about the palmar reflex. Okay. So this is thought to be the continuation of evolution when a baby had to cling to its mother for safety. So what you'll do is, if you place your finger on the baby's hand like this, you'll see automatic closure like this. Okay, and the grasp is elicited by a light stroke, which results in closure of the fingers, like I said. And there's a direct link between the palmar reflex and feeding. So a neurological loop which connects the palms with the movements of the mouth. They share a lot of connections together, and actually inhibiting this palmar reflex or activating this palmar reflex in early stages of your life is going to involve and activate those same neurological pathways that create activity and movement in your mouth, so you can start speaking and you have appropriate movement of your jaw and your mouth so you can eat. Okay, should be inhibited at 2 to 3 months of life, and the retained reflexes may result in the lack of pincer grip. Okay, poor handwriting. You might see a child who has horrible handwriting and just doesn't get it, And then one of the things you also might see is that when the child is learning to write, and they have this mouth movement, so they're moving their tongue in different directions and they're doing all these things with their mouth while they're writing. Okay, that could be a sign of somebody having a retained palmar reflex. And then speech difficulties can form this. And if your child goes through these speech therapies and things along those lines, they might be great for them, but what if they just have a immature frontal lobe system, an immature cortical system, and that's not really inhibiting that palmar reflex, and therefore they're not getting that neuronal development and that connection, that neurological loop, which connects the movements of the hand and movements of the mouth together, and therefore they have speech difficulties. So seeing a functional neurologist might be a really good idea in that case. Okay. ATNR, meaning asymmetrical tonic neck reflex. So here what we have, if you look at the picture there, a baby will turn their head to one side or the other, and you are going to see extension on that same side of the body and flexion of that other contralateral side of the body. Okay, so I turn my head to the left, extension of the left extremities, and then flexion of the right extremities. Okay, so it is a protective mechanism that prevents the baby from lying face down, but it also is activated and stimulated in the process of birth, in the birthing process. Okay, and it facilitates movement, develops muscle tone, and provides vestibular stimulation. Okay, so you guys remember the canals and the otoliths. I turn my head to the left, you get vestibular afferentation from that endolymph, which is going to deflect those hair cells, and it's going to fire through the vestibulocochlear nerve into your vestibular nuclei to create a response centrally. Okay, so the baby is moving their head and creating this response and creating muscle tone on that one side, and that muscle tone is actually firing, that proprioception is coming into the vestibular nuclei as well. So they start developing these connections in their brain and this lateralization in their brain as well. Okay, and one thing in the assistance of birth process is that it's actually reinforced. And when you reinforce this reflex during the birthing process, you actually increase the neuronal development. And babies who are born by cesarean sections or other complications and they didn't go through the normal birthing process, what happens, they didn't reinforce this primitive reflex, and that could be one cause of a baby having a developmental delay. Okay, there's some research on that. Okay, it should be inhibited at about 6 months of life, and if it is retained, the reflexes may result in difficulty in crawling, difficulty crossing the midline from one side of the body to the other, and that can be seen, for example, if a child is writing something on the paper and they cross the midline. Let's say they start writing on the left side and they start going to the right like this, and they turn their head to the right and they still have this reflex. What's going to happen, the muscle tone is going to increase on this side of the body to extend the body, and they're having trouble at the end trying to hold their pen in that position and do those fine motor movements because of that retained reflex. Okay, so every time they turn their head to one side, they want to automatically extend it, and it becomes harder for them to handwrite, for example. Possibly impaired pursuits. So another mechanism that's really cool about this ATNR is that when the baby turns their head to the left and you have extension of your arm and your leg, what happens is you're actually getting a visual cue, and you are going to be able to understand the depth of your visual field in comparison to your hand, to your arm. Okay, so I turn my head to the left and I'm looking to the left, and now if I have an object here on my left right next to my hand, I'm going to get visual information knowing that this is how far this object is away from you, yourself. Okay, so you start forming these connections in your brain. Homolateral instead of normal cross pattern movements, so you might see people or children or adults who have a homolateral gait, meaning that when you walk you have same movement like this, so you have flexion of your leg and your hand at the same time. Instead of having this cross cord reflex, you would have a homolateral gait like this. Okay, then let's go to the next one. Rooting reflex. So a light touch of the cheek will cause the baby to automatically turn their head towards the stimulus. And that's there for them to make sucking or rooting motions, and it's there for the baby to find food. Okay, so you stroke the baby's mouth like this, they'll start turning towards that stimulus and try to suck on it. And you can see, I want you to go to YouTube for all these videos, and we usually show this in club, but for the sake of time, we're not going to do that right now. But I do recommend go to YouTube, and you'll see what these actual reflexes look in infants. Okay, but we're also going to test this in adults and see if they have these reflexes still on or uninhibited. So this should be inhibited in 3 to 4 months of age, and if it stays retained, you might see hypersensitivity around lips and mouth. You might have swallowing and chewing certain foods that might be difficult, and you might have speech and articulation problems. So this reflex helps stimulate the coordination of those muscles around the mouth. Okay, then let's go to the next one, spinal gland. Okay, so stimulation. What the spinal gland is there, you can see is you get flexion and flexion and contraction on that one side of the body towards the side of the stimulus. So stimulus of the dorsal skin near and along the spine to one side will result in hip flexion toward the side of the stimulus. Okay, and there's a couple theories about the function of that reflex and why we have it. I'm not going to go into that right now because that's going to bring me go into a loophole, and I don't want to, for the sake of time, I'm not going to do that right now. Should be inhibited at 3 to 9 months of age, and the retained spinal gland reflex may result in fidgeting, and the spinal gland reflex is found in many children who wet the bed after the age of 5 years. So that's a really classic finding of this immature nervous system when the kid is wetting their bed after 5 years of age. Poor concentration, that plays a role in when a children is in school and they're leaning towards the chair, and the chair is actually stroking the back of their back a little bit, and they actually create this reflex, and every time the little stroke or touch comes in their back, they're gonna do this, and they start fidgeting, and they can't concentrate because there's constant stimulus all the time. They can't inhibit that. Okay, it might affect posture, gait, and any other form of locomotion. So really important in creating this extensor tone and this balance from one side of the erectospinal muscles over the other. Okay, so let's go. Did I go one more? Excuse me. So then let's talk about the tonic labyrinthine reflex. So we have the forwards and the backwards reflex. So you can see here in the picture, flexion of the head causes flexion of the knees and arms closer to your body. Extension of the head causes extension of the arms and legs. Okay, and it is vestibular in origin, so it provides an early primitive method in response to gravity. Okay, this is a really short-lived reflex, but it's really important for creating balance, muscle tone, and proprioception that are all trained during this process. Should be inhibited at approximately 4 months of age, and if you have retained tonic labyrinthine reflex, you might see some vestibular-related problems, poor posture, dislike of sporting activities, oculomotor dysfunctions. So once again, this movement of the head helps your eyes oriented and move from different visual fields to other, and it helps your head move with your eyes and create this vestibular response to create muscle tone. And remember that your joint position sense, your vestibular system, and your oculomotor system are all really interconnected. One doesn't work, you're going to have issues in two of the other. Okay. Then we're going to talk about the symmetrical tonic neck reflex, and this is going to inhibit the tonic labyrinthine reflex. And when a child is in the quadruped position, extension of the head causes the arms to straighten. Okay. And the flexion one is when the head causes the arms to bend and the legs to extend. So you can see that on the picture. And this, like I said, helps inhibit the tonic labyrinthine reflex and assists in transitioning to the next level of locomotion, which is creeping. And the creeping is really, really important for you to be able to develop those neuronal connections and for you to be able to form these bilateral activities from you moving your hands and your feet on the ground and having those contact cues and tactile information and proprioception coming in. And also what's really important about this is that when the baby moves their head from down here to up, they now are able to differentiate what is far away and what is close. Okay, so the visual system gets trained as well. Should be inhibited at 9 to 11 months of age. And in regards to sequence of eye training, they also help them to pursue different objects in the environment because they are able to lift their head up and they're following different targets. And your mom might walk from one point to the other, and the baby is watching and their eyes are moving, etc. If it's retained, it could result in poor posture and tendency to slump when sitting, poor hand-eye coordination, simian or ape-like walk, difficulties with readjustment of binocular vision. Okay, so a lot of things might result from these as well. So that's a lot. Okay, that was a lot of primitive reflex, and I was trying to go through them fast because there's so much information about them you could talk about. But in general, what I want you to think about, or what I want you to take out of this primitive reflex lecture, is that it's really a great window into looking at the development of the cortical system and how you're actually inhibiting those more primitive parts of the brain. Okay, so what you're going to do is you're going to test all these reflexes on your friends. I'm going to show you right now. We're going to have a breakout, and I'm going to show you how you want to test these. Okay, and they're going to give you a great window and add more layers into your neuro exam. Okay, so here we have the scoring. We have no abnormality, which is 0. 1 is partial presentation of a primitive reflex, residual presentation, virtually retained primitive reflex, and absolutely it is there. Okay, it's really prominent. So I'm going to show you how to do these, and hopefully you enjoyed. Alright, so now I'm going to show you how to test for these primitive reflexes. I got my good friend Nick here. So he's actually never had primitive reflex tested on you, so I'm interested to see what we might find. Okay, so first we're going to start off with the motor reflex. There's a few ways you can try and test for the motor reflex. One, you could use the vestibular system, or you can use sound. What I like to do is I like to use the vestibular system to change the vector of gravity and see if that brings the reflex there. So first I'm going to do the vestibular, and then I'm going to show you the sound one. So what I want you to do is just go ahead and lay here face up. So you're going to put your feet over there. And what I'm going to do, you can just relax. You can just, yep, perfect. So what I'm going to do is I'm going to bring Nick's head up here, and then I'm going to bring it down real fast, okay? And what I want to do is I want to have you place your arms like this, and I want to have them internal rotation, because in that motor reflex you often get this abduction and adduction movement. So if that primitive reflex is still there, if it's retained, we might see abduction of the hands when I bring the head down rapidly. Okay? So I want you to just relax. I'm not going to hurt you. I'm just going to bring your head down rapidly. Okay, cool. And we see no reaction from the hands. There is no other reactions that might implicate that Nick has a motor reflex. Now go ahead and stand up for me. The next way we can test it, go ahead and stand over here. It's just come behind the patient and create a sound. Okay, so that was just a usual reaction to certain, sound stimuli, so it was a little bit scary, but you didn't see a abduction of the hands or this kind of reaction that you often see in a motor reflex. The other way we can test this is we can do the trust fall test. I'm not going to do it right now, but when you do the trust fall test, you can sit down. When you do the trust fall testing, what you might see is when the patient is falling and you're going to grab them behind, is you might see this abduction of the hands reflexogenically. So that would be a positive sign for a moro. Okay? So next we're going to do the palmar reflex. How are you going to test that? You can use a pen, you can use whatever you want in order to test for this reflex. So what we're going to do is I'm going to just slightly stroke the skin of the hand like this. And if he has a retained reflex, you will see closure of the hands like this. Okay? And clearly he does not have on the right side. Now let's check the left side. So you're just going to stroke the skin, and he doesn't have it. Yeah, you want to do it a few times, and you want to put enough pressure on it too. If you do really lightly, you might not see a reaction if they have a retained reflex there. Next, we're going to test the asymmetrical tonic neck reflex. So go ahead and go on all your fours like this on the table, facing that way. And how you want to test this is you're going to grab the patient's head and you're going to move their head to one direction and then the other direction, so the right and to the left. And you're going to see if there's going to be a bending of the arm. Okay, so I'm going to do it. And you want to do this about 2 or 3 times on each side and see if that brings the, you can relax, if that brings the reflex. And what you'll see is that if Nick turns his, if I turn Nick's left head to the left like this, you'll see collapsing of that elbow, and that's a reflex if that happens like this. Or you're going to the right and then you see a collapse here, okay? So that's a positive for asymmetrical tonic neck reflex. Another test for asymmetrical tonic neck reflex, if you can stand over here, is that you're going to do a similar kind of thing, but now you're going to have the patient bring their arms up like this, and you're going to move their head to left to right again, and you can do that 1 to 3 times as well. So we're going to do this, and we're going to observe for the movement of the hands. And you can close your eyes too. You want to go all the way into rotation without hurting their neck. Okay, good. Now, if Nick had a positive, if he still had the reflex there, what would happen if I turn Nick's head to the right, his hands would start to drift to that side, really slowly. And usually we say it's a really retain if it's still there, and it's a positive with a scoring of 3 or 4, you really start to see this full body action here, okay? But he doesn't have that. Perfect. Next, we're going to do the rooting reflex. So same thing, you can use anything, any object you want to. Usually I use a pen. And what you're going to do, you're just going to look forward. And what I'm going to do is I'm going to stroke the edge of the mouth slightly like this, and you're going to see if there is any contraction of those muscles. And he doesn't have any reaction. So oftentimes when you have a positive, what you'll see, you stroke the skin, and you'll see this. It'll come up a little bit. It looks like the patient is kind of smiling, but not really. Okay, it's a reflex that happens there, but he doesn't have it, which is good. Next, we're going to do the spinal gallant. So if you can go on all your fours again, face that way. Oops, good. Then what we're going to do is I'm going to bring the patient's shirt up a little bit, and what you're going to do is you're going to stroke in the back of the next to the spine from one side to the other, just like this. Okay, and you're going to see, you can relax, you're going to see if there's going to be bending to one side over the other, or a contraction of that erectospinae muscles. Okay, and he didn't have that. So you slightly to stroke the back of the back or next to the spine, and you're going to see if that contraction happens. Okay, next we're going to do the tonic labyrinthine reflex. So first we're going to test it on all your fours, so go ahead and go back into that position. And what we're going to do is we're just going to place the patient's head all the way into flexion or extension, and then you're going to see if there's a change in posture. Then you're going to go all the way into flexion, and there is no change in here. You're going to do a couple more times, and oftentimes you'll start seeing if it's a positive, the patient will move backwards, or they start bending their arms, and they start getting into this more collapsed position, or depending whether you do flexion or extension. Okay, you can relax. Then go ahead and stand up over here, please. Same reflex that we're going to test, the tonic labyrinthine. Now you're going to go close your eyes, and I'm going to bring your head all the way back like this, and you're going to observe her sway. Okay? If the patient starts swaying a lot from one side to the other or front and back, this might be a positive for tonic labyrinthine, and you're going to do flexion as well. But clearly he doesn't have that. You can relax. And also, that's an important test for the vestibular system. We learned a lot about the vestibular system a couple of weeks ago, so we know that there is a canal system in there. There's otolithic function as well, and they all feed in the vestibular nuclei and then give you your central consequence and fire into your postural muscles to give you postural stability. So this might be a positive for vestibular dysfunction as well as a tonic labyrinthine reflex, which is a primitive reflex. Okay, so you want to look at your neuro exam and see what you're really looking at in that case. All right. And then we're going to have the symmetrical tonic neck reflex at last, which is actually part of the same test when you go on your all fours and bring your head up to extension and flexion and looking for change in posture. So that's basically how you test for all these primitive reflexes. I hope you enjoyed this week, and we'll see you next week in our last week. and hopefully it's been a good journey. Cool.